Well, thank you for joining us. I'm Davida Kruger, a certified nurse practitioner at Henry Ford Health Division of Endocrinology in Detroit, Michigan. I'm here to talk to you about what's new and around the corner in continuous glucose monitoring, CGM. Thank you for being here.
And hello, I'm Dr. Eden Miller. I'm a family physician, diabetologist, and obesity medicine specialist in Bend, Oregon. At my clinic, Diabetes and Obesity Care. What's new and around the corner in CGM?
This program is sponsored and supported by the Primary Care Educational Consortium and supported by an educational grant from Abbott Diabetes Care. In collaboration with the Primary Care Metabolic Group, here is a website for you to join for free CME, discounts on conferences and resources for clinicians interested in metabolic disorders. Free to join, please register now.
Here's the CME-CE information. Accreditation. In support of improving patient care, the Primary Care Education Consortium is jointly accredited by the Accreditation Council for Continuing Medical Education and Accreditation Council for Pharmacy Education, the American Nurse Credentialing Center, and the American Academies of PAs to provide continuing education for all of the healthcare team. This activity was planned by and for the healthcare team, and learners will receive one interprofessional continuing education credit for the learning and change. Here are our disclosures.
Learning objectives. To describe new and emerging technologies in CGM use, including OTC CGM devices and continuous glucose ketone monitoring. Interpret CGM data such as the AGP accurately to inform changes in diabetes therapy and optimize glucose control. Initiate CGM in patients with diabetes who would benefit from enhanced glucose monitoring and better blood glucose control, including those with insulin delivery devices. And finally, to engage members of the healthcare team in collaborating on diabetes management and to help patients receive CGM. So let's get started. We're going to first talk about the existing models of care and talk a little bit about how they fit into our practice and are they enough or are they not enough? When we think about diabetes, diabetes is continuous. The majority of diabetes care transpires between visits outside of clinical encounters. That's the time when the patient is monitoring their own diabetes, taking care of their own diabetes without the healthcare provider. And when we think about A1C, it's alone not enough. It may not be enough, not for what we have available now and what we know about the A1C. Using A1C alone may not be helpful to patients for them to understand their diabetes or for me as a clinician to be able to give actionable care to my patients. And when we think of blood glucose monitoring, it does have notable limitations, and it only measures blood glucose at a single point in time, not around the clock, 24 hours a day, 365 hours or days a year, when is what we need to be able to manage diabetes care. So think about A1C. Only about 50% of those individuals who have diabetes are actually achieving an A1C of less than 7%. I'm going to say that again. Those individuals with diabetes, less than 50% of them are achieving an A1C of less than 7% because of how we manage diabetes and because of therapeutic inertia. So 3 months of saying, well, come back in 3 months, we'll think about that, we'll make changes, we'll look at another A1C, becomes 3 years. And suboptimal glucose management often happens for more than 3 years due to that therapeutic inertia. And it's an economic burden to healthcare if we allow the A1C to be suboptimal and we're not giving the best care we can give to individuals with diabetes. So CGM early can support glycemic outcomes And we know reaching and sustaining A1C targets in the first year of treatment has shown long-term healthcare improvements even when control wanes over time. So if we manage the diabetes from the minute we meet the patient and get that patient to the A1C target, it has metabolic memory for that patient and over long term will pay off for that individual's long-term care. Managing glucose level early in diagnosis reduces the chances of complications, and people with type 2 diabetes that achieve target soon after diagnosis are more likely to keep the glucose in target over time. Meet that patient, get them to treatment goal, keep them there. So let's talk about the limitation of blood glucose monitoring, which for so long was the standard of care. Now, this is often what you get when you're thinking about self-blood glucose monitoring, a diary, a book. Even if this is typed up, it is hard for me to wrap my head around what does this data mean. And if it's handed to you, it often has blood on it as well. So let's look at glycemic patterns, and they're missed by blood glucose monitoring only. So what you're looking at is 4 points. The gray dots are 4 points of blood glucose monitoring. This patient, and it's really hard to get 4 finger sticks a day, this patient monitored their blood sugar at 6 a.m., right before lunch at noon, probably after lunch or right before dinner around 5 o'clock, and then before bed. Those blood sugars look really good. They were between 70 and 180, which is what we want. However, if I superimpose CGM, which is what the lines are doing, and you can see what happens overnight, the blood glucose are low, undetected hypoglycemia between breakfast and lunch, undetected hyperglycemia between dinner and bed, undetected hyperglycemia. So at a glance, the finger sticks look good, but when I superimpose CGM, this patient's blood sugars are not good at all. And this patient is on a roller coaster with what's going on. And unfortunately, they're not feeling their hypoglycemia, which is potentially dangerous for this patient. So what about the A1C? Is it still the gold standard? We didn't have A1Cs till late 70s, 1970s, early 1980s, and we were pretty pleased that we had that. It is an average of blood glucose over the last 30 to 90 days. But the problem is if the patient has a really good month and then a bad month of glucose data and then a good month, the average can actually look good. And there's nothing actionable about an A1C. If I get an A1C of 8.8, what do I adjust? Do they need more basal insulin? Do they need more mealtime insulin? And an individual glycemic control and treatment plan should not be defined by the A1C alone. It may underestimate or overestimate glucose control. An A1C of 7 could represent good, fair, or poor. It does not indicate the extent or timing of hypo or hyperglycemia. If you have blood glucoses of 40 and 400, you could potentially have a really nice A1C. It does not reveal glycemic variability. That's a roller coaster I just showed you. Limited utility for insulin dosing decisions. A1C of 7, A1C of 9. Where do I make the changes? Unreliable in patients with hemolytic anemia, hemoglobinopathies, iron deficiency, or who are pregnant. Anything that affects the hemoglobin will in fact affect the individuals with the hemoglobin will in fact affect the A1C. And then correlation with mean glucose we know can be affected across various races. We've done the research and we've seen that people glycate differently. And on the right-hand side, you can see the wide variances of the glucoses associated with an A1C. Equal A1C does not equate to equal time in range. These are patient A, B, and C all have an A1C of 7%. And you can see now, I think it's far-fetched to have target in range of 100%, although I have many that are 90 and 94%. And then patient B and C that have hypo and hyperglycemia to achieve the same A1C. And 18% of hypoglycemia is scary. Even 8% is scary. So an A1C provides only an average of a patient's glucose history. Time and range will provide more actionable information than A1C alone and should complement A1C. And keep in mind, for each 5% increase in time and range, that is clinically beneficial to the patient, and they'll see a better outcome. So A1C does not reveal glycemic variability or the extent or timing of hypoglycemia. And this was a study that was done by Kaiser, and they looked at over almost 10,000 individuals, and 11% of the individuals with type 2 diabetes said that they had a reportable severe hypoglycemic event, which means somebody had to help them. And if you look on the right-hand side of these individuals, you can see that there was the same percentage of low blood sugars to A1Cs less than 6% and A1Cs greater than equal to 9%. Now, I could look at the 14% of individuals that A1C was greater than 9% and say, well, maybe those individuals were having so much hypoglycemia that they lowered or stopped their medication. Or, once someone has one hypoglycemic event, that someone has to help them, there's always someone following behind them, feeding them to prevent that hypoglycemic event. But high A1Cs does not say the patient is not going to have hypoglycemia. It does not predict hypoglycemia. So let's talk now about continuous glucose monitoring. So we looked at blood glucoses, we looked at A1Cs, and now we're going to look at CGM and time and range. So what do the standards of care say? Diabetes devices should be offered to people with diabetes, both CGM and insulin pumps. Real-time CGM or intermittent scan CGM should be offered for diabetes management in adults with diabetes on basal insulin, multiple daily injections or on insulin pumps. And then the use of CGM is beneficial and recommended for individuals at high risk for hypoglycemia. And then finally, initiation of CGM, insulin pumps, and integrated AID insulin pumps should be provided early, even at diagnosis. We used to think people needed to wait 6 months, a year. Not anymore. Meet that person, give them a continuous glucose monitor, and think really right behind that for those individuals who may want to use insulin pumps. And then initiation of CGM should be offered to people with type 1 diabetes early in the disease, even at the time of diagnosis. And then I'm going to show you the new standards of care for 2025, which is my heart, because this says, consider using real-time CGM and intermittent scan CGM in adults with type 2 diabetes treated with glucose-lowering medications other than insulin. I'm going to say that again because I think it's amazing and it's brand new. Real-time CGM or intermittent CGM in adults with type 2 diabetes treated with glucose-lowering medications other than insulin to achieve and maintain individualized glucose goals. The choice of the device should be made based on the individual circumstances, preference, and needs. And these are in the new standards of care. Very exciting. And this is also in the new standards of care. You'll get to read this in more detail later, but it goes through what interfering substances on your CGM. And this has changed over time. So acetaminophen, greater than 4 grains. That's a lot of acetaminophen. Dexcom G6 and G7, and for Medtronic, any dose interferes, but it causes higher sensor readings. Vitamin C for the Freestyle Libre 14-day, Freestyle Libre 2, and Freestyle Libre 3. And that has to be greater than 500 milligrams, higher sensors. And then vitamin C, a greater than 1,000, is for the Libre 2 Plus and the Libre 3 Plus. And then mannitol, IV or peritoneal for the Sensionomics Eversense, sorbitol also for the same device. And all of these cause higher sensor readings than actual glucose. All right, so remember your knowledge question. The hemoglobin A1C is a gold standard of care and used to guide the healthcare provider in managing diabetes. Looking at an A1C value, advise the healthcare provider when the person with diabetes is having low blood sugar. The A1C will help with, provides enough data to determine how well the person's diabetes is controlled. Or C, the A1C provides a 30 to 90-day retrospective average of blood glucose data. Or D, the A1C and the GMI are interchangeable. Is only one correct answer, and that is the A1C provides a 30 to 90-day retrospective average of blood glucose data. It does not help us with hypoglycemia. It does not help us in determining how well the patient is doing, and it certainly is not interchangeable with A1C and GMI. This is an interesting study. It's Dr. Raven's work, and it was published in Diabetes Care in 2023. And they looked at initiation of continuous glucose monitoring and whether it was linked to improved glycemic control and fewer clinical events in type 1 and type 2 diabetes. And they looked at the Veterans Health Administration. So it's retrospective data. There's about 5,000 people in the type 1 group and 15,000 people in the type 2 group. And they're looking at 12 months worth of data. And they wanted to see if there was a decrease in hypoglycemia admissions in both type 1 and also type 2. They also are looking for reduced hyperglycemia admissions in type 2 diabetes, and then CGM use leads to reduced hospitalizations. They found yes, yes, and yes, that there was definitely, it improved the A1C in both type 1 and type 2 diabetes. CGM used in type 1 diabetes decreased hospitalization admissions for type 1. It decreased hyperglycemia admissions in type 2, and overall CGM led to reductions in hospitalizations overall, all types of hospitalizations for both type 1 and type 2. Okay, so how about time and range? What are we looking for? We're basically looking for greater than 70% of blood glucoses between 70 and 180 milligrams per deciliter, with less than 25% greater than 180, less than 5% greater than 250, less than 70 milligrams for less than 4% for less than 70, and then less than 1% for less than 55. So less than 5% on the low side and less than 30% on the high side, and we want greater than 70% time in range. And if we can get more time in range without causing hypoglycemia, we want to do that. And I would never have thought of pushing individuals to that range of that tight control of time in range without CGM. And then for your older individuals, and you have to decide what is older individual, and that becomes a little bit personal, but we have to decide what that is. What is life expectancy? How active is that individual? Are they out in the community? And perhaps you can use the greater than 70%, but you certainly can adjust that. In pregnancy, we want as much time in range as possible. This just helps you understand what I already showed you, talking about in target and how many minutes that means for that individual. So if you want to look at time in range greater than 16, almost 17 hours a day, we're looking for time in range, and really less than 1 hour overall for hypoglycemia if we're looking at a 2-week period. And this breaks it down a little bit better. It tells you that 1% of the day equals 15 minutes. And you can see that we really do not want a lot of hypoglycemia for our patients. So let's talk a little bit about the AGP report. All devices have the same report that was decided years ago. We said we need a report that looks like an EKG machine. It doesn't matter what report comes out of what brand. They all look the same, EKGs. We need that with CGM, and that's what you have. So it doesn't matter what device you're looking at. The first bar would be a summary of the values to help assess the overall quality of glucose management. That's where you're going to find your time in range, your percentage of time in range. That's where you're going to find your GMI. What is GMI? Remember I said it's not interchangeable with the A1C because the GMI only looks at a particular time that you're looking at. So I'm looking at 2 weeks of data. It tells me that the glucose that would be related to an A1C or similar to an A1C where that particular time would be for this patient 7.5%. If I looked at 30 days, it would give me a GMI for 30 days. But it also gives me the time in range so I can coordinate that. It also tells me glucose variability. It also tells me average blood sugar. If I look at the middle bar, it shows all values as if collected over a single 24-hour period. So this is 2 weeks of data, and it makes it look like 24 hours so that I can wrap my head around it. So it's midnight, noon, midnight, and you can see definitely overnight, this individual is having hypoglycemia. I don't have to look very hard for me to be able to see that. And then if I look at the third panel, that's my daily views. I can go and see which days this individual is having the hypoglycemia so I can act on that hypoglycemia. So if it's only 2 days, that's different than if it's every single day. And it looks like almost half of the days this individual is having hypoglycemia. So the AGP tells me time and range. It gives me, takes the 2 weeks and makes it look like 24 hours so that I can help that individual with actionable data. And then it tells me on a daily basis for the 2 weeks what's happening in that particular days. And so I can give really sound feedback to the individual with diabetes, and we teach them how to interpret this as well. So what's happening overall with technology in the U.S. market? And this was looked at in July 2024. And just like the data I've shown you, blood glucose monitoring is decreasing while other technology, mostly CGM is driving it, is increasing in terms of utilization in the U.S. market, as it should be, and insulin pumps are not too far behind. So this is all of the CGM devices available right now. It is a moving target, but you can go to the toolbox and you can have this for your very own because there's too much data on here for me to review right now. I will tell you that the most important thing to understand is that all the devices on the market are accurate and they are easy to use for the individual. These that I'm showing you right now are reimbursable. And for the most part, all individuals can get coverage, whether it is commercial and or Medicare, as long as they're on insulin. And we're moving to, as you saw in my earlier slides, some different coverage. But take a look at this on the toolbox, and I'll go into more detail on some of the newer components of this particular slide. This is the most recently FDA-approved CGM devices. You can also get this on the toolbox. And on the left-hand side is your Freestyle Libre 2 Plus and 3 Plus. The important thing to know with the 3 Plus is if the patient is on the 3 and decides to move to the 3 Plus, they can use the same app or the same reader. These are all approved. All of the Libres on this slide are approved for 2 and above and can be used in pregnancy and has Medicare coverage. And you can see the integration on insulin pumps. The G7 is newest on this particular slide. And again, it is for use for 2 and above pregnancy. It's a 10+ day. Libre is up to 15 days. And we can get Medicare reimbursement. And you can see the integration. Guardian Connect. Sinclair is not quite ready for us yet, but it's coming. And we're awaiting launch for the Guardian 4. And it's also standalone. The Guardian Connect, Sinclair, these devices have rechargeable transmitters. The others are integrated. And then our Eversense 365 is your implantable. And understand that it is implantable for 365 days, but there is an external transmitter that does need to be charged. But these are the most recently FDA-approved CGM devices, and it is a little bit of a moving target, and we try to keep you up to date. So these are the over-the-counter CGM for use in non-insulin patients. The Stelo is on the market right now. It's a 15.5-day wear, 30-minute warm-up. Goal is glucose range 70 to 250. It does not have an alarm, so that's important to understand. And there's no prescription because there's no insulin coverage. This is over the counter. The Freestyle Rio is not yet on the market, but it will have glucose range 40 to 400 with a 1-hour warm-up. And again, it is over the counter, no prescription required. And then the over-the-counter for people without diabetes is Lingo. And Lingo is, in fact, on the market. It's designed to track blood glucose levels for those without diabetes, provide insights to help users understand how the body reacts to food, exercise, stress, and it is a 14-day sensor as well. Again, over the counter, no prescription. And a new partnership that is not yet on the market. Abbott is building a new CGM to be integrated exclusively in the Medtronic insulin pump, which will then do away with having to charge a transmitter because it will be built in. So stay tuned for those updates. So what is professional CGM? It's a patient who is new to your practice. You would own that sensor. You would place that sensor for the patient. They would come back in 10 to 14 days, either blinded or unblinded, until you had an opportunity to write a prescription and the patient to own their own. It gives you an opportunity to understand what the data is and what the data isn't if you want to make changes for that individual. There is reimbursement for placement of that sensor, and that's 95250, and then also for when the sensor comes back for interpretation. Right now, both Dexcom and Abbott have professional, but as of December 31st, Libre Professional will no longer be available. But look at this. These are two of my patients that we decided to put professional on because we had no idea. Again, remember that a CGM is just an average retrospective look-see of the last 30 to 90 days. And I have an A1C, I have no data. And look what I found on both of these patients, 15% low on the left and 27% low on the right-hand side. Different decisions when I have CGM data than when I have just an A1C. So what would you do with this data? Patient A1C is 7.5, was 8%, metformin twice daily, sulfonylurea twice daily. GLP-1 was started 2 months ago. He feels well, no complaints, denies hypoglycemia no matter how I ask the question. He's doing some finger sticks but only when he feels badly, and he doesn't feel badly, so I have no data. So we place a CGM. This is what we get. 6% low, 58% time in range. And that tells me a lot more than just an A1C of 7.5%. Most of this data is hyperglycemia with 36% hyperglycemia. So what are we going to do to quickly review and interpret the data? This patient is definitely riding the waves. We ask the patients to tell us what they see because we want them to be a partnership in this. And we first start by identifying the hypoglycemia. Then we look at hyperglycemia. And understand when you correct hypoglycemia, you'll see more hyperglycemia. And the hypoglycemia is probably causing some of that hyperglycemia from the patient over-treating the hypoglycemia. Look for patterns. Look at that roller coaster this particular individual is going on. And even the time in range glucose data is high time in range. And then look at the variability, the high and low. This is what makes the patients feel uncomfortable with the highs and the lows and causes the fatigue. And then if you have other data, look at the progress that patient may have made. Okay. This is another patient, 62-year-old male, on glargine, 30 units twice daily, aspart, 12 units 3 times daily before meals, 6 feet, 252 pounds. His BMI is 34, A1C is 8. He started on tirzepatide 2.5 about 3 or 4 weeks ago. His insulin was appropriately lowered by 30%. He does have personal CGM. He asked if he could have his tirzepatide increased, and I said, yeah, but I want to see some data before we increase your tirzepatide. This is the data he sent me, or I was able to go in the cloud and look. What do you see? And what are my next steps? 27% hypoglycemia, even with a 30% lowering of A1C. Had he not had CGM, he told me he felt good, I probably would have gone ahead and given him the next dose. But I need to lower his insulin before I increase his tirzepatide. So before increasing tirzepatide, I worked with the patient to eliminate the low blood sugar. I took his Lantus down to 8 units twice a day, aspart 4 units. Tirzepatide was still 2.5, and his A1C had come down to 6.8%. Now I have only about 3% low blood sugar. And when I increased the tirzepatide, I decided to stop the insulin because He wasn't on that much insulin. I was going to watch him closely, see what happens. And in fact, he did very well. And we were able to titrate him without insulin to the 15 milligrams. But again, without CGM, I would not have known that. So what are we looking for when we look at that middle panel of AGP? These are the desired ideal glucose profiles. You can see the first one is not flat, not narrow, and not in range. And we really want to see flat, narrow, and in range. And then as we make adjustments, we'll see the flat, narrow, and not in range adjust, because our goals are to get greater than 70% time in range. And over time, as we adjust, we're going to see changes, and we can see that the profile comes down to flat, narrow, and range. So when you start out at the top, make small adjustments. Maybe you're making mealtime insulin adjustments, or making sure the patient takes the mealtime insulin before the meal. Then we go back and we look in a couple of weeks and make further adjustments until we get to the flat, narrow, and in range, much like I did in both of the cases that I just showed you. So what about CMS expanded CGM coverage? In 2023, April 16th, we had a huge change. During COVID, CMS got rid of needing to do finger sticks, but in April of 2023, they agreed to getting rid of having to have 4 injections a day and only needed to be treated with insulin. So any type, any frequency, once a day, doesn't matter whether it's long-acting or short-acting. If the patient is not on insulin, but has a history of problematic hypoglycemia, recurrent level of 2 hypoglycemic events less than 54, despite 2 attempts to adjust the medication or modify treatment plans, or a history of 1 level 3, that's glucose less than 54, requiring a third-party assistance, we can get CGM. So either insulin or hypoglycemia, either one you should be able to get coverage. Now, I will say that most of Medicare, you have to send the prescriptions to a durable medical equipment store. Some of them will allow you to send to pharmacy, but if you send to pharmacy and it's denied and you think that patient should qualify, send that patient to a durable medical equipment store and see if in fact they qualify. And this is coding for reimbursement. If a patient comes in with their device and wants someone in your office to train, you can use 95249 and get reimbursed. Professional, I reviewed for you, and that is 95250. If the patient, and that's for placement of the CGM, if the patient is wearing their own, or for interpretation of professional, you're going to use 95251 for reimbursement. And then that is in addition to your evaluation and management codes. So don't forget to bill. In most patients, you can get reimbursement for interpretation. They say monthly. I found that most insurances will allow 4 times a year. So when we think about it, what is the best tool for practice? Is it finger sticks? Is it an A1C? Is it CGM? And I'm not going to throw the baby out with the bathwater and say that I don't need A1Cs anymore, but I really need CGM to help me understand what's going on with that A1C. Okay, so let's move into another topic. We're going to talk about diabetic ketoacidosis, a topic I think we should talk more about, but we're not. Diabetes ketoacidosis is a serious complication of diabetes. The condition develops when the body can't produce enough insulin. Insulin plays a key role in helping sugar, a major source of energy for muscles and other tissues, as it enters into the body. Without enough insulin, the body begins to break down fat as fuel. This causes a buildup of acids in the bloodstream called ketones. If left untreated, the buildup can lead to diabetic ketoacidosis. Type 1 diabetes, DKA, occurs in 30 to 40% at diagnosis, and 6 to 8% of those with established diabetes annually. And then type 2 diabetes, which is less common, but the risk increases with age as patients have less of their own insulin on board, and is highest in those aged 60 to 90. And it's also an increased risk for those on SGLT2 inhibitors. So what are the symptoms? Diabetic ketoacidosis symptoms often come on quickly, sometimes within 24 hours. For some, these symptoms may be the first sign of having diabetes. That may be how they get diagnosis. And it may be something like very thirsty. I've heard stories of, I knew my child was having some issues because every time I turned around, they wanted something to drink. And then they were perfectly potty trained or slept through the night and they were bedwetting because of all of the fluids. Feeling a need to throw up and throwing up, having stomach pain, being weak or tired, being short of breath, having fruity scented breath, and being confused. And this is a hierarchy of the symptoms as the person's DKA gets worse. More certain signs of diabetic ketoacidosis, which can show up in the home blood and urine tests, include high blood glucose levels, high ketone levels in the urine, and we also have the ability to check that in the blood. So at home, we're checking for ketosis, but a visit to the ER will tell us about DKA. So what is available today to determine ketosis or the risk of DKA at home? We have either urine ketone strips or blood ketone strips, which can be read in this meter that you can see on the screen. So that's all we have right now. So I discuss this with my patient. I give them a prescription for one or the other. I ask them to fill it. At the time, they don't necessarily see it as urgent. And often when they're sick is when they realize they never filled that prescription. They don't have anything at home to check for ketones. This is an ongoing problem. So what can we do to make it better? Around the corner is a bio-wearable one sensor for both glucose and ketones. Imagine that. The patient would have a sensor. It would check for glucose. If the person was having problems with ketones, it would also show the results to ketones. It's a first of the kind, a dual monitor system that will enable people with diabetes to continuously monitor glucose and ketone levels in one sensor, and it's under development right now. The goal is early detection of diabetic ketoacidosis, a potentially fatal condition. This technology, currently in development, received breakthrough device design from the U.S. Food and Drug Administration. This designation is designed to expedite the review of innovative technologies. So hopefully sooner than later, we'll have something available to talk about and maybe use in practice. So let's change tacks again and talk about artificial intelligent biosensors for CGM. I found this to be really interesting and very exciting because when I think of artificial intelligence, I'm not quite sure what I think, but something big out there. And it didn't quite register with me that using CGM and integrating that data into an insulin pump, as well as sending that data to a receiver and to a phone, was artificial intelligence, and that artificial intelligence was helping us make good decisions. So artificial intelligence, AI, algorithms in combination with continuous monitoring technologies have the potential to revolutionize chronic disease management. The recent innovations in both CGM and the closed loop highlights the far-reaching potential of AI biosensors for individual health care. And it goes on, the article I was reading went on to talk about how the AVA is supporting this and even using AI when they do retinopathy exams and other exams for people with diabetes. Well, we're going to talk about AI in biosensors for CGM and how does that relate back to getting the data we need. So this shows you a typical CGM system, and it usually consists of a glucose regulation element, a physical chemical transducer element, a wireless transmitter, and a receiver. Those are things we're kind of used to, but the glucose recognition element provides a high selectivity towards the glucose and then plays a key role in the success of CGM. The function of the transducer element is to convert the glucose concentrations that we get from the CGM to a measurable analytic signal, and that data is then transmitted wirelessly. I mean, all of that is going on behind the scenes to get us the data we need that's transmitted either to a reader, a phone, or, as you can see in this particular patient scenario, an insulin pump. This shows you the artificial intelligent biosensors for continuous glucose monitoring, the history of it. You know, we talk about back in the early 60s, that big backpack of a biosensor that was utilized to regulate the insulin. Now, clearly, we weren't going to give that device to a particular individual to walk around the streets, but that's where we started. And we obviously have to have a start point. And this is a graphic representation of CGM systems throughout the years. I remember when the Freestyle Navigator came to the market, it wasn't very accurate. It was like 20% off. It wasn't that small. There were just some issues, but we were so excited to have that. And the patients that utilized it, did not want to give it back when it came off the market. And then you can see the MiniMed 670G. That was the first hybrid closed-loop system to use this AI technology. And then the market continues to grow so that right now we have 4 or 5 closed-loop that are talking to the CGM. AI is giving the information over to the insulin pump to help the insulin pump make good decisions so that it knows when to adjust the insulin, what's happening with the glucoses, both high and low. And this shows you the biosensor in terms of glucose monitoring, but how do we get that information out of the tissue? So it's how the sensors attached to the skin is able to grab the interstitial fluid, and AI helps process and interprets the data that then is transmitted over to that little receiver that you can see at the top of the slide. So the sensor and the transmitter, which are in one device, is placed in the skin, pulls out the interstitial fluid, and through all of this chemical mechanism and AI, the data is grabbed, analyzed, transmitted, and sent over to the receiver. And then finally, this shows artificial intelligent biosensors for continuous glucose monitoring, how it attaches the sensor to the skin. It also shows the concentrations of the glucose and how it transmits wirelessly to a smartphone. And then the AI data processing can be grouped into interfacing data, data classified for storage, data model, and analyzing the data. And then AI, artificial intelligence, can then transmit it over to the insulin pump. So the person on the left wearing the insulin pump interfaces and transmits the data over from the interstitial fluid into the transmitter, into either the reader, the pump, and then we have glucose predictions on the closed loop sessions, and it goes to the smartphones or onto the pump. And it's the AI that is helping with that glucose predictability. So in summary, AI has 3 main applications: closed loop algorithm, glucose predictions based on CGM biosensors, AI algorithms and calibrations of the CGM biosensor based on AI algorithms. CGM sensors can be worn up to 15 days. A calibration algorithm is required for the insulin pump after a sensor change, which helps resets the algorithms on the AI. And it is necessary for insulin pumps to take closed-loop decisions and to learn from the data adaptation. And then closed-loop therapy technology is a perfect embodiment of CGM and AI providing numerous clinical opportunities and technical advancements. And we're seeing that every year where these closed loop devices can think better because of the algorithms and the direction that the AI provides through these algorithms.
Now let's talk more specifically about the healthcare team. CGM and the healthcare team. The lack of diabetes specialists is particularly concerning given the relatively low adoption of CGM or continuous glucose monitoring, as well as insulin delivery devices and other diabetes related technologies amongst our fellow clinicians. Adoption of CGM can seem to be a daunting task. The underutilization of these tools is often driven by the perceived time constraints, insufficient staff support, and lack of awareness of the significant and consistent clinical benefits provided by these technology. This is precisely why the healthcare team is so important in the process. We want you to be the one to open the door to CGM for the person living with diabetes. You can outsource CGM, its initiation and application to other diabetes champions to avoid inertia being traced back to you. You could do clinic initiation, but you need to identify your team and create a workflow that suits your practice setting that efficiently addresses all those aspects of CGM identification, application, and that follow through. My clinic is 950 square feet. I got one medical assistant, and we can accomplish these steps in mere minutes, less than 5 minutes. But you got to take the time to decide the pathway for CGM utilization. It will increase your time efficiency with patient interactions, both personally and virtually. When you are creating your team CGM diabetes, you got to think about the components. It's those front office staff people. It could be one or two or several. You need to have a way to identify or CGM review appointments and flag the charts regarding CGM technology. What brand, what type of diabetes, so that all of the caregivers in the team can see it readily. I have reminder calls with encouragement to bring all diabetes-related technology and any kind of journal or homework assignment looking at the effects of food and exercise and stress and medication adherence. We also, when they come at the appointment, we collect those devices or we verify the phone connection. That can be at the front office person. That can also be at any person along the line of the diabetes team. We start the ball rolling on data access. Often, this is done prior to the appointment. When I saw patients yesterday in clinic, my staff had already the day before taken that data and placed it in the chart, so I didn't have any kind of barriers. And having those flagged CGMs, those flagged appointments for review, all of that heads up look is going to improve your efficiency. Because then when it gets handed off to the back office person or the diabetes champion, and that will be somebody that you're going to identify in your office who is familiar with all the CGM systems, or at least the ones you're prescribing and utilizing. In addition, we have to understand the concept of a reader or an application on your phone. In addition, what about personal application of the device and setting up the closed loop? What do I mean about that? Again, just yesterday, I walk out, I talk to my MA, I talk with her about the type of CGM that I want applied in the second room, and she walks in, asks the patient, do you want a reader or an app? And they download the app, they do the username and password. We also write the username and password in the chart sometimes because you and I know we've got some tech challenged people and talk about removing barriers. People forget their usernames and passwords. So I write it in their chart. And then what we do is walk them through that application of the sensor. We close the loop by either doing share codes or data confirmation, because guess what? You want to make sure the loop is closed, because when you leave and then they come back, you want to be ready for that front office staff to be able to download it. You need to have a login. It's not that hard to do. It's just a few systems that have that desktop cloud-based application for those apps or plug-in for the readers. And once you have a username and password, usually the clinic champion knows it, but all of my staff knows it's readily available, because it is important to be able to access that data, download the AGP, and incorporate it in that shared decision making. And so when this is set up, when you've identified the front office, the back office, the champions, they each have their roles. They each have those things that they need to do to be successful in the application, initiation, and continuity of care. It'll allow you as the clinician to be able to obtain that data, to sit there with the patient during follow-ups, either in person or virtually, and have a very meaningful discussion, as well as opening your eyes as the clinician and the person with diabetes to own their data, own their disease a little bit more. We are all on Team Diabetes. This is a team effort. Not only that, work is made light by many hands. Diabetes is a challenging disease that you never get a break from, but you can be entirely successful if we work as a team, incorporating the person with diabetes to live their best life, taking diabetes along for the ride, empowering them to be participant in their lifestyle, their medication adherence, their own data, learn themselves as an individual, as well as equipping the family and caregivers so they feel safe, so they feel a part of supporting that individual. You as a clinician are sometimes at the front lines, leading all of these team members. You're prescribing, you're engaging those individuals, you're identifying them. We also have other parts of the team that every one of my colleagues have different kinds of opportunities. I incorporate pharmacists or PharmDs. In many cases, they're at the front lines as well with application. I get my nurses and my CDCESs. I love them. They're so helpful. They have the time to be able to identify those nutritional and lifestyle and medication type of engagement, and to help equip the person with diabetes to understand it. Don't neglect the dietitian. There's some amazing data coming out about CGM, looking at glucose control and dietary impacts. The medical assistant, all of those individuals that are specialists on the periphery, including podiatry and ophthalmology, our exercise specialists, our health coaches, our community centers that are looking at continuous glucose monitoring. I've even been talking to dentists. The mouth is so imperative in health and long-term complications. Don't forget your prior auth department, prior authorization departments. They need to know what you're thinking. You need to document that in your notes so you can have better communication to try and remove some of those barriers to acquire this much needed technology. So with that, identify your team, empower them to work at the top of their skill set. Give all of those different tasks to those individuals so that you as a clinician and the person with diabetes can successfully incorporate technology and take CGM along for the ride in their diabetes management.
And then a final issue and a continuing issue that we work with every single day. CGM uptake is very low for vulnerable diabetes populations, but how to achieve equitable use remains complicated. I don't think any of us have the answer. I think what I think is important is that we're talking about it, that we know the uptake is low for our vulnerable diabetes populations, and we're really all trying to see what can we do to make a difference in this area, and we really need to bring it up first and foremost so that all people across all walks of life are afforded the opportunity to use continuous glucose monitoring. And then when we think about health disparities, we need to look at the location of the health disparities, socioeconomic status, racial, ethnic disparities. What kind of insurance companies or coverage is available? Are there gaps in that insurance coverage, which is what I often see when I see gaps of patients not coming in for their visits? We want to make sure that it's not because they need a ride, or they lost a job, or they can't get in because they have to work. We really need to look at what's happening with why we're not seeing our patients on a regular basis to decrease some of these disparities. What are the technological challenges? Do patients have the right phones? Do they have computers at home? And then health literacy is very important to make sure what we teach is learned. And then all can impact the access and use of CGM by your patients. Telehealth and diabetes education can help. We know that if we can provide some telehealth for those individuals who cannot get into the clinic, we know that that really does help for them to be able to manage their diabetes. We did it during the pandemic, and we continue it now. We know that it does make a difference in reaching so many more people and helping them manage their diabetes. And we can teach how to use a CGM through telehealth. So in summary, A1C alone is not an appropriate actionable marker when making therapeutic changes. Self-monitoring of blood glucose has significant limitations as well. Lack of symptoms does not mean patients are not experiencing dysglycemia. Goal of therapy is to reduce hyperglycemia without causing hypoglycemia. The AGP allows for visualization of patterns for the healthcare provider, the person with diabetes, and caregivers, and is suitable for all reading levels, reduced language barriers, and numeracy is not required. How do you want to practice? Please think about this as you go forth into your practice after this presentation. This is a resource toolkit for you. Here's the link and the links to pages devoted to the individual devices, both professional and personal, including insertion videos. Some of the slides I showed you would be in this toolkit, links to references used in this presentation, links to download the deck and review the presentation to share with colleagues who can also learn and get and earn CME credits as well, extensive cost and use of data, and then a list of helpful resources from the ADA, Diatribe, AAFP, the Association of Diabetes Care and Education Specialists, and more. To receive your certificate, please complete the survey at the link below or use the QR code to the right. Thank you.